Thank you, Xiaoye. So today we are going to be talking about B vitamin disorders. So we're going to be talking about B vitamin disorders, and these will be case-based presentations for disorders related to the biosynthesis and transport and absorption of riboflavin, folate, pyridoxine, cobalamin, biotin, and niacin, which makes nicotinamide adenine dinucleotide. So the first case is a 25-month-old male. He first came to medical attention at 23 months because of a possible seizure episode, but an EEG that was performed was interpreted as normal. And then at 24 months, he was noted to be pale and have a heart murmur. Pediatrician did a complete blood count, which showed anemia and neutropenia that, as you can see, is quite severe, and received 4 packed red blood cell transfusions. There was family history that was generally mostly non-contributory, cancers and a paternal great-grandfather, and the family being of European and Native American ancestry and non-consanguineous. So on physical examination and further history, it was identified that he had had developmental regression over the past few days with refusing to walk and decreased use of words. And this was preceded by a 3-day history of fever, cough, and difficulty breathing, which was due to a respiratory syncytial virus infection. On examination, he had ataxia and nystagmus. CT and MRI brain revealed sinus disease, but no brain abnormalities. And the spine MRI identified a diffuse abnormal T2 signal of the entire spinal cord. And so initially, the differential diagnosis was primarily bone marrow failure syndromes. But again, due to the kind of rapid regression and severe pancytopenia, trio exome, critical trio exome was performed, and this identified biallelic variants in the transporter SLC52A2. One of these, as you can see, is a missense variant that's previously reported as pathogenic, inherited from the father, and then you can see an in-frame deletion inherited from the mother that was classified as a variant of uncertain significance. So what does SLC25A2 do? So it encodes a riboflavin transporter. You can see over, and the condition is called Brown-Violetta Van Lara syndrome. You can see over on the left-hand column the typical phenotypic features of this condition, and then our patient is shown over on the right, and you can see again the nystagmus and abnormal eye movements, ataxia, difficulty breathing, all being manifested in our patient. After the exome results came back, we performed biochemical testing that I'll show you in a moment. And again, as I'd mentioned, he had developmental regression that's also seen. So what is riboflavin? It is vitamin B2 and is an essential vitamin. The sources in our mostly from our diet, but our intestinal microbiome can make some riboflavin as well for us. This is like all B vitamins, a water-soluble vitamin, and you can see the average requirement is only about 1 milligram per day. You can have nutritional deficiency, particularly in individuals who are on peculiar diets, and nutritional deficiency causes cracking of the corners of the mouth called chelosis, and can result in a sore mouth or sore throat, as well as hair loss, vision problems, and anemia. So there are actually 3 of these riboflavin transporters. The one, again, we're talking about is in the middle. The SLC52A1 is expressed only in the placenta, intestine, and kidney, and gives riboflavin deficiency because you can't absorb riboflavin, again, if you don't have the intestinal transporter. SLC52A2 is ubiquitously expressed, but is most highly expressed in brain. And so again, transport from the bloodstream to the brain is going to be impaired with Brown-Violetta-Van-Leeuwen syndrome type 2. And then SLC52A3 is Brown-Violetta-Van-Leeuwen syndrome 1. And again, it also is an intestinal transporter, as well as, again, other locations. You can see here the stomach, pancreas. This is just a graphical representation, again, with SLC52A3 being on the luminal side of the parietal cells, SLC52A1 being on the basal cell of the intestinal parietal cells, and then again on the right, the SLC52A2, that again is the blood-brain barrier transporter. So what is riboflavin good for? It's good for almost everything you need. So you can see over on the right here that riboflavin is synthesized first to flavin mononucleotide and then flavin adenine dinucleotide. And FAD is important in a wide variety of processes that you can see. I won't bother to read them to you. They typically catalyze 1 or 2 electron transfer chain reactions. Again, you can see from the slide that there are kind of hundreds of these that are involved in a wide range of important cellular metabolic functions. I'll show you in a moment, but what we can see on biochemical testing is abnormalities of acylcarnitines and due to the fatty acid oxidation requirement for riboflavin as a cofactor. So here again, it's just another example. So you can see at the top there are a number of amino acids whose degradation requires FAD, as well as fatty acids that I mentioned, choline and other things. So riboflavin was initiated at 10 milligrams per kilogram per day. Again, as I mentioned, this is super high dose. So we standardly just need 1 milligram per day. Again, for 1 to 3 years of age, it would be 0.5. And so I'll kind of, you can see kind of we started and then kind of advanced monthly to kind of 100 times or more the dose, the typical recommended daily allowance. So we see, so these are results from plasma, urine, and CSF metabolomic analysis. Again, I won't read them to you, but you can see that there are wide-ranging abnormalities in various acylcarnitines, low levels of various amino acids, and the other kind of abnormalities, including neopterin-related metabolites. So 3 weeks post-treatment with riboflavin, his nystagmus had resolved. He was walking, holding his parents' hands, pulling himself up and cruising along furniture. Eating was normal. He had returned to his more pleasant disposition, and the hematologic abnormalities responded dramatically, and he was no longer neutropenic. This is just showing, again, the heat map of the various abnormalities that we saw. The first 2 columns over here are on the right, are the CSF and the plasma before treatment, and then you can see the kind of changes after treatment, again, in various vitamin and cofactor-related metabolites, lipids, and amino acids. So case 2 is a 5-day-old that presented with new onset seizures that were responsive to pyridoxine. DNA testing was performed and identified an intronic, homozygous intronic variant in ALDH7A1, and biochemical testing revealed low levels of elevated piperacillate and low levels of piperidine 6-carboxylate. So this is the pathway. You can see the block here of lysine being converted either into piperacillate and then piperidine 6-carboxylate, or into saccharopine and alpha amino adipic semialdehyde and these are interchangeable. Again, he was on pyridoxine therapy at 100 milligrams daily. We had recommended kind of a temporary increase to 300 milligrams daily with acute illnesses, but it's not recommended to do higher than 100 milligrams daily regularly because that can cause a peripheral neuropathy. And initiation of a lysine-restricted diet, again, you saw up earlier in the pathway, the lysine biosynthesis of these biochemical compounds. And then arginine supplementation, because arginine and lysine are both dibasic amino acids and compete for a transporter. And so if you give them arginine therapy, that again is going to outcompete lysine and kind of also help with lysine restriction. Moving on to case 3. This is a 5-month-old who was admitted for new onset seizures and hypernatremic dehydration. He had a history of chronic diarrhea after taking a course of amoxicillin for an upper respiratory infection. He was noted to be irritable on examination and found to have pancytopenia. His total plasma homocysteine was quite elevated. His vitamin B12 was normal, and bone marrow biopsy revealed pancytopenia with megaloblastic changes. He developed respiratory distress. He incidentally had a brother who was born outside the United States and passed away right before a year of age with similar symptoms. Parents were consanguineous. So on laboratory testing, so his vitamin B6 level was quite low, and rapid exome sequencing was performed and identified a homozygous missense variant and SLC 46A1, which encodes folate transporter. In follow-up, he was treated with leucovorin 10 milligrams intramuscularly daily. Now at 5 years of age has normal growth and development, no seizures, and no hematologic abnormalities. There are 2 different folate disorders. So the one he has is the one that's kind of in the middle here, the hereditary folate malabsorption. This transporter is ubiquitously expressed, whereas there is a separate transporter that encodes the transporter on the blood-brain barrier that transports it into the brain. So for hereditary folate malabsorption, again, this typically occurs in the first years of life. It has megaloblastic anemia. This is not seen in cerebral folate deficiency because, again, you can absorb in that condition, you can absorb folate from the intestine. You just can't get it across the blood-brain barrier. In both disorders, they can have regression and seizures, as well as other focal neurologic findings. Again, in hereditary folate malabsorption, they can have poor growth and diarrhea. Again, not seen with the cerebral transporter deficiency. As far as folate levels go, again, with the hereditary folate malabsorption, both blood and cerebral spinal fluid, you're going to have low levels. However, again, in cerebral folate deficiency, the blood level is going to be normal. It would just be the CSF folate level that would be normal. These are the 2 genes that encode the transporter that's seen here. And again, the treatment is different for these 2 disorders as well. So case 4 was born at term via repeat C-section with no complications. At 2 months of age, was noted to have poor weight gain and poor oral intake. And then at 4 months of age, was identified to have pallor, macrocytic anemia, and received packed red blood cell transfusions. The hematologist that he was seeing at the time performed a vitamin B12 level and was normal. And so they did not have a cause for his pancytopenia, but thought it was potentially viral. And then, and did not do any more testing or treatment. And then at 6 months of age, he presented to our hospital emergency room with severe megaloblastic anemia, again, thrombocytopenia, and acute kidney injury. You can see here his total plasma homocysteine level was unmeasurable because it was above the reportable range for our diagnostic lab, and his methionine level was low. His methylmalonic acid level was 2, and you'll see why we checked that in a moment. DNA testing identified intronic variant and 2 intronic variants, in the MTR gene that causes cobalamin G disease or methionine synthetase deficiency. So his clinical course, he had significant critical illness related to atypical hemolytic uremic syndrome, was treated with plasmapheresis and renal replacement therapy for many weeks in the intensive care unit, developed respiratory failure, and was hospitalized for a total of 2 months. And we essentially threw the book at him. So we gave him hydroxycobalamin at 30 milligrams subcutaneously daily. So this is the standard that's available if you were to call up your pharmacy is 1 milligram per mil that is injected. So that's even a high dose, but we had it compounded for him, and he was receiving 30 milligrams daily. And then again, various other important cofactors for methylation, leucovorin, pyridoxine, betaine, and folic acid were all initiated. So I just saw him in clinic about 3 weeks ago. He currently is 8 years old. He does have some residual renal injury, but it seems like it's non-progressive and is on enalapril with well-controlled hypertension. He does have some recurrent immune glomerulonephritis, for which our nephrologists treat him with intermittent steroid bursts. He also has a longstanding problem with asthma and eczema that I think is unrelated, and he just completed 2nd grade with in regular school, but with a modified curriculum. He is short, but his weight gain has been good. So this is just a graphic representation. So there are many steps in order to get B12 from our diet into an active form for which as cofactors for methylmalonyl-CoA mutase, shown up here at the top, and methionine synthetase, shown here. These involve transporters in the intestine, as well as protein in the intestine, intrinsic factor that's required for absorption. 2 transporters, again, like you saw with brown violet layer, the riboflavin. So there's one on the luminal side of the intestinal parietal cell and one on the basal side that transports it. Once it gets into the bloodstream, you can see over here on the left this protein transcobalamin 2. There is a transcobalamin 1 and a transcobalamin 3 that bind vitamin B12, but vitamin B12 is not bioavailable to cells from those 2 proteins. It's only B12 that's bound, or cobalamin that's bound to transcobalamin 2, that is biologically available to cells. It then gets transported into the cells, and there is a multi-step process that converts it again into the active cofactor forms. There are some steps, again, that are shared between these 2 cofactors. The most common of these cobalamin disorders is shown here, cobalamin C disease. And so in these various conditions here, you will have elevations in both methylmalonic acid as well as homocysteine. But then there is kind of a divergence of the biosynthesis, where there are a couple of enzymes now that are specific for making adenosylcobalamin. That's the cofactor for methylmalonyl-CoA mutase. And then a couple of enzymes that are important for synthesizing methylcobalamin, which is the cofactor for methionine synthetase. And again, this is the disorder he has, cobalamin G methionine synthase deficiency. You can see, again, all of these kind of methyl donors here. And again, kind of why we kind of trying kind of multiple, in addition to vitamin B12, and multiple cofactors to treat his disease. This is just a summary for completeness. Again, there are these disorders listed over on the left, CBL, C, D, F, J, and X, that have both methylmalonic acidemia and hyperhomocystinemia. Cobalamin A, B, and D, two have only elevated methylmalonic acid, and then cobalamin D1, E, and G have only elevated total plasma homocysteine. Again, as I mentioned, cobalamin C is by far the most common. You can see it's overall in the general individuals that have cobalamin disorder, that it accounts for the vast majority of these, whereas each of these other disorders, and notably, again, kind of cobalamin G, you can see is quite rare. In looking at kind of the different disorders and the phenotypes that you see, you can see that with cobalamin C, there's a wide range of features that are primarily either neurologic. Very severe forms can have prenatal presentation with non-immune hydrops and other fetal manifestations prenatally. Generally, the other disorders, with the exception of cobalamin F, generally do not have prenatal abnormalities that are seen. This is the table showing the neonatal and infantile presentations. Again, I'm not going to read all of these to you, but again, note that there are quite a number of neurological features that are seen in cobalamin C disease that can also be seen in various other disorders. And then there are, particularly with cobalamin C disease, there's a wide spectrum, and particularly in our population that is majority Hispanic, many of them have mild presentations. But again, there are kind of adult onset presentations that can be seen with these vitamin B12 disorders. So again, for most of these disorders, again, we need to be mindful that even in adults presenting with neurologic or hematologic abnormalities, that they can have these inborn errors of metabolism. The overall incidence of cobalamin disorders is somewhere around 1 in 50,000. As I'd mentioned, cobalamin C is relatively high in Hispanic population. And again, the long-term outcome can be quite variable. Again, this is for cobalamin C, that if you're on the severe end of the spectrum, even with vitamin B treatment, they can still have neurodevelopmental disability. However, the outcome for mild patients, again, as long as they're diagnosed early and compliant with B12, is essentially normal. There are genotype-phenotype correlations. I, again, kind of won't read them all, but there are certain variants that are associated with early onset severe disease with cobalamin C. As I mentioned, there are variants that are milder and typical of more late onset disease. This one here particularly is the one we see in our Hispanic population. They can have retinopathy in cobalamin C, and again, you'd see that only with the early onset severe disease and do not see retinopathy with late onset disease. Again, some genotype-phenotype correlations with cobalamin D and cobalamin E, with a mild mutation seen in individuals from Spain and Portugal. So as I mentioned earlier, treatment is with subcutaneous injections of hydroxycobalamin. For most of these disorders, cyanocobalamin does not work. It is not as bioavailable when taken either orally or as an injectable. And so hydroxycobalamin is what needs to be used. Typically, again, for cobalamin C, particularly if we think they're going to be mild, we would typically start at about 1 milligram daily or every other day, and then kind of increase as needed based upon the routine monitoring labs of homocysteine and/or methylmalonic acid. For individuals that have refractory hyperhomocystinemia, betaine, which is tetramethylglycine, and again can serve as a methyl donor to drive the reaction from homocysteine to methionine, may be used. Again, folate or folinic acid may be considered as, again, particularly if they're not well controlled only on hydroxycobalamin. Notably, this is, even though the methylmalonyl-CoA mutase deficiency, they are on a protein-restricted diet. Diet therapy is not necessary for these disorders, and Chuck Venditti at the National Institutes of Health and his group have published data indicating that in individuals they've seen who have been prescribed a protein-restricted diet, that they have growth deficiency and other abnormalities that are not seen in those on an unrestricted diet. Monitoring of growth and development is important, as well as laboratory monitoring, complete blood count, again, particularly make sure that they don't have a macrocytic anemia. If they have methylmalonic acidemia, because that can deplete carnitine through binding the carnitine and being excreted in the urine, would be indicated. And then again, for cobalamin C, particularly the severe form, routine ophthalmologic evaluation. Case 5 presented at about 3.5 months of age with extensor posturing that was diagnosed initially as seizures, and so treated with phenobarbital. He had been otherwise healthy up until that point. Then at about 12 months of age, he visited India, where he developed fever and had subsequent loss of developmental milestones. Family history was unremarkable. This is his urine organic acid analysis with elevations of 3-hydroxy isovalerate, as well as 3-hydroxy 3-methylglutaric and 2-hydroxy glutaric acid. And you can see here elevations on the acylcarnitine profile of propionyl carnitine, or C3, and hydroxypentanoyl carnitine, or C5OH. So these are reflecting propionic acid and 3-methyl crotonic acid. And then enzyme testing for biotinidase showed essentially zero activity, so severe biotinidase deficiency. So what does biotin do? Biotin is a cofactor for 4 different carboxylases: propionyl-CoA, 3-methylpropionyl-CoA, pyruvate, and acetyl-CoA carboxylase. And so again, this explains the elevation of propionyl carnitine, as well as 3-methylpropionyl carnitine, or C5OH, that was seen on the acylcarnitine profile. I'll introduce the term biocytin, and I'll kind of, before I show you the next slide. So biocytin is the biotin lysine complex that's left over after carboxylase degradation, and it's thought that that this is a toxic compound. So all of those 4 carboxylases that I had mentioned have a specific lysine residue to which the biotin is bound. This enzyme shown here on the right, holocarboxylase synthetase, is responsible for taking biotin and sticking it onto the lysine residue of the carboxylases. And then biotinidase is responsible for both removing biotin from the lysine residue of a degraded carboxylase, as well as removing biotin from the protein-bound biotin from our food. So this disorder is about 1 in 60,000. Biotinidase overall is probably about 10 times more common than holocarboxylase synthetase deficiency. Overall, it's thought that holocarboxylase synthetase is probably a little more severe and presents earlier than biotinidase, which again would make sense biologically, since you can't stick it on there if you don't have holocarboxylase. But if you've got biotinidase, you can kind of, again, kind of overcome it with diet potentially, or supplementation. In biotinidase, symptoms typically occur about 3 to 6 months of age. but again, there is a wide range and it can be variable within families. So what are the features that we see? So they primarily are skin and neurologic, and so alopecia, dry skin, and skin infections are seen. They have developmental delay, low muscle tone, seizures. As well, you can see focal neurologic signs like ataxia, hearing loss. They can also have biochemical derangements related to the elevations in lactate and propionate. And then again, you see kind of some of the more rare findings that are seen in biotinidase here. The good news, again, with this is most of the disorders we're talking about, and the reason it's important for diagnosis and treatment is that these generally, this disorder, like many of them, improves with biotin therapy. Once hearing loss has occurred, that is not correctable, but again, skin and some of the developmental things may be correctable. We typically would treat, again, with kind of an ultra high dose, 10 milligrams of biotin daily. As I mentioned, the seizures, low muscle tone, skin rash, and hair changes typically improve rapidly. But again, if they're already hearing or visual impairments, those will not get better. And again, if there's developmental delay, while they won't get better, like kind of from a standpoint, they won't get worse, and they would continue to have progression of development if they're young once they're instituted on biotin. So this is just showing you a couple of individuals kind of before. You can see the kind of skin and hair changes, and after biotin supplementation. Again, the skin and hair changes and low muscle tone shown there. Okay. So case 6, so we did not see this individual until about 16 years of age. But as far as his history goes, he had an episode of acute ataxia and respiratory failure at 2 years of age. At that time was found to have a very elevated creatinine kinase enzyme activity, but had normal biochemical studies and recovered rapidly. And again, this was kind of attributed potentially to some sort of infectious process. He then was generally well until about 13 years of age, when he presented because of a 4-month history of weight loss and progressive muscle weakness, was again found to have elevated creatinine kinase, and had muscular dystrophy panel sent that was normal, and again, kind of improved clinically, and nothing else was done. And then at 16 years of age, he finally presented to our hospital with a 2-week history of diplopia, ringing in his ears, problem swallowing, and weakness that progressed to acute myoencephalopathy with respiratory failure. He had a muscle biopsy and nerve conduction velocities, as well as mitochondrial DNA testing that was non-diagnostic. He had a chromosome microarray analysis that identified 8 kb deletion of 13q34 that encompassed exons 1 and 2 of the NEX-D gene. And so DNA sequencing, because this was a good phenotypic fit for his condition, DNA sequencing was performed, and missense variant was identified on the other allele. So what is NAD? So nicotine adenine dinucleotide is an important cofactor for many different reactions. There are 2 enzymes that you see here, NEX-E as well, that is important, converting the R-NADPHX to S-NADPHX. And then NEX-D here is shown. And again, these are kind of important. NAD, of course, is involved in multiple dehydrogenases, such as pyruvate dehydrogenase and various components of mitochondrial complex 1 that are seen. These are his metabolomic results before and after. So you see over on the far left, these various metabolites that are related to niacin, notably quinolinate, nicotinamide, 1-methyl-nicotinamide, trigonylene, and N1-methyl-2-pyridone 5-carboxamide. What you can see is basically 1-methyl-nicotinamide, which we essentially almost always detect in plasma, was completely absent. And then you can see these are z-scores across the bottom, which are standard deviations from the mean. So you can see, again, for the N1-methyl-2-pyridone 5-carboxamide, a z-score of -6. And then in blue, you see after 11 months of niacin supplementation, the biochemical improvements and normalization of the various biochemicals related to niacin and NAD. I should say, maybe as point of reference again, we would consider anything kind of within 2 standard deviations of the mean. So from here to be normal. So again, kind of complete normalization of these biochemical abnormalities. He was on niacin 100 milligrams per day and basically returned to his baseline with completely normal school performance and normal physical activity after a year after supplementation, as well as normalization of creatine kinase enzyme activity. This again is kind of just showing a heat map of the metabolomic results. We also see perturbations of a wide range of compounds, certainly with mitochondrial function, but also biochemicals related to peroxisomal function and amino acid synthesis. And again, you can see over here on the left, many things in, again, with phosphatidylcholines, lysophospholipids, and plasmalogens. You can see they're all very low. So you can see over here the key that, so the bluer, the more blue it is, the lower it is. And so you see here, again, kind of pre-treatment, and then after 11 months of treatment on the right, significant normalization of these complex lipids that were low at the time of diagnosis. And then finally, there is a related disorder of NAD biosynthesis. This is shown over on the right. And there are a number of 3 known genes that are disease-causing at present. The first one here is kynurenase. The second is 3-hydroxy-anthrylic oxygenase. And then NAD synthetase 1 shown down here at the bottom as part of the NAD salvage pathway. And so basically, these are multi-system disorders. They generally look like the Vactorel syndrome, but can have other manifestations as well. So in regards to Vactorel, so they have vertebral abnormalities, including fused vertebrae and hemivertebrae. They can have congenital heart disease, both left-sided and right-sided congenital heart disease, kidney developmental abnormalities of the kidneys. They can have short limbs and short stature, and then things not typically seen in Vactorel, such as cleft palate, eye anomalies, sensory neural hearing loss, and tracheoesophageal fistula can also be seen. There are biochemical abnormalities that we can see on metabolomic testing with elevations in kynurenate, kynurenine, so these compounds up here, as well as trigonylene that are kind of downstream products from kynurenine, and hydroxyxanthine, which again is a downstream product of 3-hydroxyanthrylate. So as an overall summary of these disorders, so vitamin and mineral disorders can have, and I should say, before I say, I thought I put this on the slide. It's thought that, so Sally Dunwoody made a mouse model of, I think both KYNU and HAAO knockout mouse models. And the offspring were essentially normal, unless she put them on a niacin-restricted diet. And then once she put them on a niacin-restricted diet, she did see the birth defects in the mice. And so it is thought that kind of maybe kind of having kynurenase enzyme deficiency alone may not be sufficient to manifest the birth defects, that it probably is kind of a combination of, again, kind of having kynurenase deficiency and then, having something like hyperemesis gravidarum or something else that are, peculiar vegan diet or something where they kind of would not be getting enough niacin or, not taking their prenatal vitamins. So as an overall summary, vitamin and mineral, these B vitamin disorders can have varied manifestations, but notably many of them share features, particularly neurologic, hematologic, and dermatologic. So again, particularly if you see neurologic and hematologic features together, you should really be thinking about B vitamin disorders. One of the points to be mindful of, again, is a number of these are transport disorders. And if it's not the intestinal transporter, then the blood levels are typically going to be normal. Okay. And so again, for example, the Brown-Violetta Van Laer syndrome, that's the brain transporter, right? And so if you're testing the blood level of riboflavin, it's going to be normal. Similarly, for cobalamin C or cobalamin G disease, it's not the transporter, so the B12 level in the blood is normal. There are some, again, that are the intestinal transporter, and those should be low in blood. But again, kind of that the normal level in blood does not exclude a B vitamin disorder. Again, rapid diagnosis and treatment is important because it can often reverse many of the symptoms or halt progression. So again, just as a summary, riboflavin transport disorders present with anemia and pancytopenia, as well as general and focal neurologic symptoms such as nystagmus and ataxia. Pyridoxine responsive seizures are typically well controlled with vitamin B6 alone. And excessive dosing can cause sensory neuropathy. Disorders of folate transport include hereditary folate malabsorption. Again, this is a disorder where the blood level of folate would be low. They can have neurologic and hematologic manifestations, whereas cerebral folate deficiency, again, is only neurologic, no hematologic manifestations, and the treatment is different here is with folinic acid. Cobalamin disorders can present, again, hematologic and neurologic sequelae. They have elevated levels of homocysteine and or methionine, methylmalonic acid, and treatment is with subcutaneous hydroxycobalamin. Biotin disorders manifest with seizures, hearing loss, skin and hair abnormalities, and the two disorders, biotinidase and holocarboxylase synthetase, are known. And then finally, for the vitamin B3 disorders that are for NAD biosynthesis, there are these two enzymes here, NADPHX and E, NADPHXD and E, that have, again, neurological features, a myopathy and developmental regression that can be cyclic, and treatment with niacin is generally very effective at reversing symptoms. And then finally, I'd mentioned the NAD biosynthesis and recycling disorders that cause multiple congenital anomalies. And again, as I'd mentioned, it's thought that probably loss of function variants of these genes alone are not sufficient to have congenital anomalies, but it probably is that along with kind of maternal niacin deficiency. So I'm stopped there, and I'm happy to take any questions.